but I call it a stubborn toxic adenoma. So it's a 46-year-old woman who was actually from out of state. I saw her, I talked to her actually. So for patients that are out of state from me, where I don't have privileges, I do a phone consultation after I get all their records to review, and we talk about their case, and it's all completely pro bono. But she had subclinical hyperthyroidism that was diagnosed in 2015. Was recommended to start methimazole, but she declined, and subsequent to that saw 6 other different endocrinologists who all gave her the same recommendation, and she continued to decline their advice. But she, in the interim, she started to have this growing mass in her neck and had progressive compressive symptoms. So she was very interested in radiofrequency inhibition. Her TSH was low as August, but her free T4 and free T3 were not that bad. She did have a 24-hour uptake, 21.9%, and showed a focal uptake in a right 5-centimeter thyroid lobe nodule. On ultrasound, the nodule was 6.7 centimeters, as I mentioned, overall 47 cc's in volume, very heterogeneous, high bone isotopic. And she did, I also, for my toxic nodules, also biopsy at least once, and it was require that, and she did have a biopsy, and it was benign. So the challenges of this case at this moment in time was that this is a very large size nodule. I could poor visualization of the lower pole, so you're not quite sure how much further it goes down. Of course, this is all through remote sort of interaction with the patient as well. And as I presented earlier, we know that there's decreased efficacy of thermal ablation for much larger toxic adenomas greater than 20 cc's. And the patient's history really questioned whether or not she was going to be a good patient in terms of patient compliance and follow-up and such. So I counseled her that really, I did not think that she was a good candidate for thermal ablation for all of these different reasons. She said, okay, and that was it. And then a month later, she shows up in my clinic for her thermal ablative procedure. So there was obviously some miscommunication there. But since she had flown into New York just for the procedure, she talked me into doing it, and we did it. So the procedure was ultrasound-guided RFA. It was a transisonic approach. I did do vascular first ablation. She had multiple pretty robust media leading arteries. Total ablation time was 25 minutes, 26 seconds. Total energy applied over 62,000 joules. And there was really no peri-procedural complication during this time. For all of my patients, I prescribe Xanax as well, as Jesse said, the Kuo protocol. I have my patients take NSAIDs prior to the procedure and then continuous 48 hours after. And for these larger nodules that I ablate, I actually do prescribe a post-procedure steroid taper. She didn't take any of that. I prescribed the steroid taper to the nearest pharmacy that I could find, to the place that we were doing the procedure. She told me she was going to pick it up, and she did it. And then she went home. But about 2 weeks after, she says, I've got some overlying erythema and some drainage. She's now back in her home state, so we asked her to send a picture. This is what it looks like. And we said, okay, well, here's some antibiotics. And she'd go, I don't want to take antibiotics, I'm worried about my gut. Right? So we're like, a couple days later, she sends us this picture. Still doesn't want to take antibiotics. And it gets to this point where this is the picture she sends us, and this is probably 2.5, maybe 3 weeks out. I was like, okay, you can't keep going on like this. If this continues to collect in your neck, we're going to look at an airway problem. You need to find someone locally that can take care of this. If you can't come back to New York, you can't keep going on like this. You didn't pay any attention to the instructions that I asked you to do after the procedure, and you're not even paying attention to what I'm telling you to do now. So obviously, you don't want me to take care therapy, but you gotta find someone who can. And so in my head, I was like, oh, this is perfect, right? Because someone else is gonna take care of my complication for me. Not quite. So she continues to get larger and larger, gets this big, goes to the emergency room, and it has a pretty extensive CT that obviously showed. I call it the mushroom sign, or the A-bomb sign, that's consistent with rupture. So, mushrooms out. Here's the capsule of the nodule, and then it mushrooms into this big cloud. So that's nodule rupture for sure. In the emergency room, there's an on-call interventional radiologist who sees her and decides that he wants to aspirate, and then it looks like this. And then she comes back to New York to see me. So when we got this picture, and she said, "I give in. I'm gonna come to New York so you can take care of me." I had her booked for the operating room, even though she really didn't want to do I was like, okay, I'm gonna get you into the operating room. We had her on the list. She came in, and I saw her in clinic, and essentially the two puncture sites, or the two holes at this point, were completely connected. And there really wasn't residual, that much residual necrotic tissue or abscess or anything. And I didn't actually feel that I could do anything more to debride that space operatively. So I had a long talk with her. I sat her down. It's like, okay, I will not take you to the operating, but you have to like do what we ask you to do. Otherwise, we are not going to get this to heal for you. So she finally decided that she would take the antibiotics. And I debrided it at bedside, put some silver nitrate on some of the exploding granulation tissue, and she went on antibiotics. And over the next 2 months, this thing slowly heals. And she's now euthyroid. VIR is 30%. And actually the contour of her neck is not horrible, but certainly there are some scars there. So what do we know about nodule rupture? The incidence is pretty rare, and I think we went through this a little bit earlier. It almost always is a delayed presentation, and in fact, I would say almost every complication with ablation is in a delayed presentation, especially when you compare it to surgery. Surgery is pretty immediate, but with ablation, it's all delayed. It usually presents with acute swelling and overlying erythema and pain, and almost always it will extrude anteriorly because that's where the capsule, as Iman alluded to, is thinnest. And that's actually what you want, because if it ruptures medially or posteriorly, that's what can cause acute tracheal compression, and there have been deaths due to this. So you want it to actually extrude anteriorly, and you want it to actually extrude on its own if you can. And the earlier the better. The etiology is unclear. There's some hypotheses that it's due to delayed hemorrhage, differential pressure within the nodule. So sometimes, we sort of intentionally underweight the margins near the capsule because we don't want to cause thermal injury beyond the capsule, but then we really pump energy into the middle of the nodule. And that differential pressure perhaps can contribute to the dynamics that kind of lead to rupture. There's also some thought that if patients are excessively palpating and such, that could also be the case as well. And certainly this patient, she refused to take systemic antibiotics, but she was like gladly putting weird ointments and stuff on her neck as well. So perhaps that helped contribute to things. Risk factors, it does seem to be much more common with larger nodules and increased energy delivered. So again, I pumped over 62,000 joules into this nodule, so that certainly put her at risk. Management is mostly conservative, although again, especially if there's rupture posterior medially, that might require operative debridement, and sooner that is done, the better for everyone. So a cautionary tale, like Jesse, I'm an endocrine surgeon, I don't have complications until I do. Which if you do, inevitably you will.
phase steroid, is it a standard guidelines, or you just for the toxic nodule?
It's not standard. It's not standard, but I actually do. I prescribe it not infrequently. I do find that patients have a lot of periprocedural swelling that kind of peaks for 8 to 72 hours after. And for larger nodules, if it abuts the nerve, I have had patients have transient hoarseness just from that. So, I prescribe it for larger nodules or any area of multiple nodules. The total ablation zone is on the larger side, greater than 4 centimeters, then I'll do it. And operatively, we give IV Decadron at the start of the case, and that has been shown to help with transient neuropraxia as well. So for the most part, I think there's no harm in it. I've conferred with my medical endocrinology colleagues. I do 20 on the day of procedure, 10 the next day, and 5 on the second day post-procedure. And at that dose, there really shouldn't be any physiological effect, but it does help as well. And for nodule rupture, there's some evidence that steroids is not also helpful to heal those as well.
So, a couple of questions here. With regard to the etiology of rupture, you want to put the patient on antibiotics. Did you ever have cultures where the radiologist aspirated? Because this looks like involving abscess, right? Then, there's got to be so the first question is, are we using adequate sterile technique? You have a needle in the neck for a long period of time, multiple passes of a large needle, and should these patients perhaps be treated prophylactically with antibiotics, very procedure. The second thing is that, also being a broad spectrum general surgeon, I know that tissue necrosis causes intense inflammation, and that the rupture itself. The real question is it infectious or is it non-infectious inflammatory? And I don't think anybody's answered that question yet. But probably somebody next time they see this kind of rupture needs to do a tiny FNA or something so that we can get cultures and find out what percent of these are a technical issue, which are just because of the consequence physiologically of the therapy.
Yeah, no, all good points. So I do these procedures in my office in the procedure room, but all the techniques I use are actually taken from the OR. So all sterile drapes, all sterile towels, heather cleanse, prep. I'm sterile glove and sleeve up to past my elbow. I'm wearing a mask, the patient's wearing a bouffant. And people are right. I mean, technically, it's not a sterile case, but there's no harm in doing that and treating it. I think what we may or may not realize is that we are creating a huge pocket of dead necrotic tissue that sits there for a really long time, and you just need a little bit of seeding to get it infected. Now, whether this was an abscess or a nodule rupture, I'll tell you, I've had abscesses too. Abscesses are much more obviously purulent drainage. They are ready to burst at the seam. And those are easy to get cultured. We did culture her, but hers was really particulate. And so I think with the nodular rupture, it's much less purulent, and it really is like necrotic tissue that is extruding from the wound. So there is that. But antibiotics do help, I think, largely because of the inflammatory response that is involved.
Do you routinely give prophylactic antibiotics now, or no? No. So none during the procedure either?
Not for what?
Before or after the procedure, not?
Not routinely, and we don't actually give antibiotics for our operations either, because the risk of infection is still incredibly low. For me, when I've had abscesses and infections, not rupture, they've actually been, there's always been a viral prodrome for the patient. So even though it's a virus, somehow it's like they're seeding this, again, necrotic pocket. So the incidence is rare enough where I don't give it routinely, but the minute it even hints of something going on, those patients are on antibiotics.
For a tapered steroid pack, you do that, and size criteria you go off of, is that for hot and non-hot?
Yeah, it's purely size.
What size threshold?
Any anticipated zonal elevation area greater than 4 centimeters on one side. And I don't do large compliant. that's my personal thoughts on viral illusions.
What do you think, Rachel?
I have one question.
I think if
Oh,
you can give somebody
what is
a
your
comment,
diagnosis?
don't put the pressure. It's gonna be
What
right
is my
there.
Diagnosis. Cause and
Diagnosis.
diagnosis? I think, I think it is, the diagnosis is nodule rupture. The cause?
What is the cause?
Well, huh?
With a source of infection.
Um,
Before not the rupture.
yeah.
Infection?
Sober infection after.
You know, she really didn't have, again, like all my other abscesses and infections, they had some sort of viral prodrome leading up to the event, but she really didn't have that. I think for her, really, it was a large nodule. I probably put in too much energy. And then I don't know what else she was
Did
doing.
you have a blood check? Blood check. I mean PCR, PES,
blood
blood check. Yes.
No, we
When she
didn't,
went
for
to the
infection.
No,
Yeah, no, we didn't, they did not do blood cultures. They did do wound cultures and stuff, but they did do blood cultures at the time. Because she never had fever. She never was hypertensive. She didn't have other signs of the systemic infection. She
What?
didn't have white count, really.
What is the cause of rupture?
Well, that's a good question for you. I've done my literature research and I've come up with poor answers, so.
We have several cases of nodule rupture after treatment of benign side of the nodule. Initial CBC shows absolutely normal. Understand? WBC
Yes.
normal.
White cells.
Yeah.
White
The white blood cells
cells.
is normal, yeah. But
And
that was
the-
in her case.
And the CRP, ESR for normal. Response to antibiotics is not so good. So it is not infection. The theory is oozing, slow, continuous bleeding. As you suggested, different nature. Can you show the last slide? Nodule. Well oblated and unoblated tissue is separated because well-oblated tissue decreased and became fibrosis, and separation that induce bleeding, vessel damage between two. This unoblated tissue is not shrink because of some kind of adhesion with the outside tissue, especially stromosis, that can induce continuous bleeding inside the tissue. Therefore, the tissue is very weak because of continuous bleeding and stimulation. So you should not puncture the skin. That can induce necrosis of skin. So do not puncture. Antibiotics is not so effective. For oozing, what is the best drug?
Prednisone.
Pardon?
For me, it's steroids. It's prednisone.
Prednisone.
Steroids.
Exactly. Steroid is the best choice. We experienced the nodule rupture. We did aspiration, antibiotics, admission, no impact. But recently we changed our mind. Over the past 5 years, we had 3 cases of nodule rupture. Was successfully recovered by prednisone.
1 month.
It's a long
One month.
Please try steroid.
One month?
Yes.
It depends on the patient's condition.
How about those?
But if you have a case like this, you have to start with 25/2 for a week, and 25.5, then half and half. You do as a subacute thyroiditis, it's the same. But in our experience, we have 4 options on those 1,000, etc., generally correlated to high dose of heating. And in 3 of these 4, as they leaked, we made a culture on which may be a little bit dirty, I mean. There was the staphylo everywhere, staphylo epidermidis. So we put together steroids and amoxicillin for 1 month, resolved completely. Because there is a sort of infection after.
Infection is
After, from the skin, spontaneous goes in and persists. Anyway, in this case, in that case, it's sort of like that.
I would also like to emphasize 2 other important points from this case. One is patient selection and how critical that is to success. Like, obviously, she was a poor patient for this, and I knew it, but I still let myself get talked into it. And patients will try to talk you into doing these procedures, and especially if you're starting out fresh, you don't want to be caught in this situation. You don't want this. And then the second is you got to own your own complications, which I kind of knew, but I was hoping I wouldn't have to, but I was still stuck with it anyways. And by sending her to someone else, it was even worse than if I just taken care of it myself. So, those 2.
Just one more quick question. Has anybody ever had a patient that ruptured and then retreated that patient? I'm curious. I have a patient referred to me who had ruptured outside and now has persistent nodules retreated.